So why are we talking about acromegaly in pregnancy? Well, we're going to talk about the challenges to become pregnant, the risks during pregnancy, and the potential risk to the child after birth. So as you saw so eloquently presented earlier, surgery on the pituitary gland is very, very specialized surgery. And no offense to my cardiology or kidney doctor colleagues, but the pituitary gland is the most fascinating organ. It's only the size of a pea, and yet it controls all of your body functions. So these are all, you're all very well familiar with growth hormone and what that does, but it does make many, many other hormones. And in particular, you'll see on the, do I have a pointer? So you'll see, so this is the front of the pituitary gland. Some of you may have had to be on cortisol to replace the glucocorticoids. It controls your thyroid hormone, but it also controls your gonads. So for women, our ovaries, and for men, their testes, are all controlled by this same little pea-sized gland. Growth hormone, of course, that you're near and dear to, but also prolactin, which can impact pregnancy and is actually our breastfeeding hormone. So this small, tiny little gland controls really all of your body functions, and anything that impacts part of the gland can affect all of those different hormones. And when we think about the ovaries in particular, which we, for women need to, of course, to become pregnant, you'll see that the ovaries are responsible for making estrogen and progesterone. The ovaries sit beside your uterus, but they are under the control of LH and FSH. And we could replace these with the testes, and what we would see here is testosterone instead of estrogen and progesterone. This whole pathway is essential in order to become pregnant. So preconception care is such an important part of medical care in order to get healthy pregnancies at the end, and really it's about healthy children and healthy moms at the end of a pregnancy. So why do we spend time talking about it with patients and really looking at it? Well, the first thing is birth defects or congenital anomalies. So all pregnancies have a 2 to 4% chance of ending with a baby who has a minor to major congenital anomalies, and we want women with medical problems to have that same risk. It's never zero, but we want the risk to be as low as possible. Losses, miscarriages, but also especially for people with chronic medical conditions, you want to optimize the complications and associated conditions. So with acromegaly, that would be diabetes and high blood pressure, for instance. You want those well controlled on the right medications before the woman becomes pregnant. And you want to modify the therapies. There's no drug company that does clinical trials in pregnancy. Any trial excludes women. So we're often challenged with what is the safest medication in pregnancy, but we do know some that are safer than others. And we do want to make sure that we don't change things unnecessarily when we have good blood sugar control, good blood pressure control, for instance. So this is my favorite slide to show medical students and residents around preconception care. So this is when you get pregnant, right here, and you miss your period. You're supposed to get it, so this happens in the middle of your cycle. 2 weeks later, you should get your period. If you don't get your period, then you might be pregnant. So it depends how on it you are for your periods, but a week later you do a pregnancy test and it's positive. Well, by the time that pregnancy test is positive, the neural tube, which forms the brain and the spine, has already formed, the eye and ear has formed, and the heart is on its way. So this is 1 week after you've missed your period. You're called 3 weeks pregnant because you're actually called 5 weeks gestational age because we start counting from the last menstrual period, but the baby is 3 weeks old. And then by the time you actually get in to see someone, should you be fortunate enough to have a primary care doctor these days, or a specialist that has access, right, which is getting harder and harder, which is the other thing I love to talk about. But by the time you actually get in to see someone and talk about changing medications or optimizing things, it's really a done deal by then. So all of the major organs are formed. So if we want to prevent damage to these organs from medications or from poorly controlled blood sugar, for instance, it has to happen before you know you're pregnant, because by the time you know you're pregnant, there's not a lot of advantage of changing things because you've already had all of these organs develop. So the other thing that's important is some people think because they have a medical condition they can't get pregnant. So we want to make sure that we reinforce, and again I'm biased because I'm a firm believer in having children, so that we have to talk about it and have realistic expectations. And that applies to no matter what the chronic condition is. It's harder with rare conditions because we have less evidence for rare conditions. So what do we talk about before pregnancy? We talk about the impact of acromegaly on being able to conceive. So are your chances lower if you have high growth hormone and a pituitary adenoma? How are we going to optimize that? And how are we going to make it as safe as possible by having that reduction in tumor size, so having that surgery before you attempt pregnancy and that biochemical control. So too much growth hormone, there are many things that can impact fertility, so your ability to become pregnant. So you need functioning LH and FSH from your pituitary gland. You can't have too much prolactin from that pituitary gland, and you need functioning ovaries as a woman and functioning testes as a man. So if you have too much growth hormone, there is a suggestion that it can have direct effect on the ovaries. So even though your pituitary gland is working well, the ovaries aren't responding normally and aren't making an egg to enable you to get pregnant. Too much prolactin, prolactin-producing adenomas are much more common than growth hormone-producing adenomas, but many people with acromegaly, about 25%, will also have a high prolactin. And if we get that prolactin down, then periods may resume. And then, as mentioned earlier, one of the risks of surgery, although a very low risk in good surgical hands, is damage to that normal gland. And that damage can already be there pre-surgery and can actually recover after the surgery, or it could have been fine prior to surgery and was one of the risks of surgery, although, as mentioned, that's rare. But if you damage the normal gland, you don't have LH and FSH, so you're not going to get ovaries functioning, and your testes aren't going to work either. So this is just a diagram to show you that, you can imagine, and I'm just thrilled to see the new study on early diagnosis, and we'll make sure that patients in Ottawa get a chance to participate, because you can imagine there's less damage when it's here, much more damage when it's bigger, and much more chance that that normal gland is not going to produce the hormones you need to become pregnant. So the earlier the diagnosis, the less likely you are to have permanent damage from that normal gland, which you need to conceive. So this was a study about a decade ago looking at 55 women, so the numbers are small, right? All of the studies in pregnancy are small. Looking at their menstrual cycle, so you can see 30% were normal, 70% had an abnormal cycle. So amenorrhea means no periods, oligomenorrhea means irregular, infrequent periods. And sometimes it was related to high prolactin. That's the easiest one to fix, quite honestly. There's a great medication that works well for getting prolactin down. Some were related to the tumor mass effect. Getting that mass taken out will sometimes improve that. Others were only related to the growth hormone excess, so that's why there's a feeling that growth hormone excess itself, independent of the rest of the gland function, may play a role. So getting control of the growth hormone may restore periods. And then the other, there can be more than one of these causes. So luckily, all of these really are treatable. So this is a case I love to talk about for two reasons. First is, it was actually infertility that got her acromegaly diagnosed. So, there's infertility both for men and women is not that uncommon. Acromegaly is a very uncommon cause, but speaks to the importance of advocating for people to get that early diagnosis and get people thinking about pituitary problems, in particular acromegaly, as a potential cause. And she was having trouble getting pregnant and wasn't having periods, and only in retrospect, and if the right questions are asked, do you notice other things as well besides just not having periods. The initial MRI showed a big lesion with extension up into the suprasellar region where the nerves to the eyes are, and into that cavernous sinus that you saw earlier is where those important nerves that move the eyes live. The prolactin level wasn't high, it was 23. The IGF-1 was very high. So followed that Endo Society treatment algorithm, surgery was done. I'm speaking a little bit out of turn, but it's hard to get all of that tumor out that's sitting in the cavernous sinus because of those carotid arteries and nerves sitting there. So had 2 debulking procedures, started octreotide, and IGF-1 level was still high, so it wasn't perfect control by any stretch, but was able to conceive and have a healthy pregnancy. So this was a case of unknown acromegaly presenting as infertility because of the impact of that growth on pituitary function. So what about men? So again, no offense to my surgery colleague, but I always suggest that men going for pituitary surgery sperm bank before they have the surgery. It's like disability insurance. You hope you never need it, but it's nice to have. So just in case something happens to their LH and FSH and ability to make sperm, they do have something. Now that doesn't help you if they're already unable to make LH and FSH and their testes aren't functioning. But if they are functioning, it's a few $100 a year to get the sperm in the bank, and if you never use them, you can discard them or give them to someone else. So for any pituitary surgery, I'm a big believer in sperm banking. So what about for women? So prior to pregnancy, we get the growth hormone levels as near normal as possible, get that surgery done, and we need to treat diabetes. So high blood sugar puts your baby at much higher chance of a birth defect. Sleep apnea gets worse in pregnancy. Blood pressure gets worse in pregnancy. So we need to get all of those things under control. And then we need to review the medications that are being used to treat the acromegaly and these other conditions, and need either to continue or stop them prior to pregnancy, because if we stop them when the baby's 10 weeks old, you're not really going to affect as much as you will if you stop them prior to pregnancy. So there are 3 major groups of medications that you might need to use in order to get pregnant. The somatostatin analogs, dopamine agonists, such as Acromegaly that we use for treating, especially if there's a high prolactin, and then the growth hormone receptor antagonists. There's really very, very little safety data, so the question always is, do we stop them before pregnancy, as soon as the woman knows she's pregnant, or do we continue them? And the somatostatin analogs, they do cross the placenta, so when we think about safety of drugs, we want to know, does the baby see the drug or not? And there is evidence that they cross the placenta, but there's no clear proof of harms, but the studies are very, very small. So the ideal world, you wouldn't want to use it, especially in the beginning of a pregnancy, but you need a healthy mom in order to have a healthy pregnancy. So if there is tumor growth or uncontrolled disease, then you may elect to continue them, recognizing that there's not a lot of data, or stop them for the first trimester and then reintroduce them. The dopamine agonists, we have a lot of experience in pregnancy and they appear safe. And there's very little data on the growth hormone receptor antagonists. There's 27 patients who were on it that were reported when they got pregnant. They stopped it when they got pregnant and there were no birth defects. But again, there's very little data, so it's a judgment call weighing the risks, benefits, and the unknown. So interestingly, in pregnancy, again, that pituitary gland is very active in pregnancy. You have a placenta and a baby that you didn't have before you were pregnant, and lots of hormone levels change. So we actually can't use the same markers in pregnancy as we can use, so it's harder to follow. So how do you know if the tumor's growing or your growth hormone's getting worse? It can actually be hard to tell because everybody has a higher IGF-1 when they're pregnant. So it's more based on symptoms than actual biochemical markers. The good news is growth hormone does not cross the placenta, so the baby does not see high growth hormone levels. So baby is not going to be born with high growth hormone. So the big, one of the risks if we stop these medications, because we're not so sure whether they're safe in pregnancy or not, do things really get worse in that 9 months off treatment? And the good answer is likely not. So only 8% actually grow. So if you're 9 months without your treatment, are you going to run into a catastrophic event, losing your vision, having a bleed into a growing tumor, and it's rare, but it can happen, but it is rare. So if it does happen, since we can't measure that IGF-1, what do we look for? Well, are your headaches getting worse? Are you getting any loss of vision from it pushing on the, so this is a larger lesion that's now, pushing on the optic chiasm there, so you would expect some visual field. And then you might have to restart the medications, and worst case scenario, they might need surgery during the pregnancy. If you need surgery, it's always safest to get it in the second trimester rather than later or earlier in pregnancy, but obviously not a great decision to have a general anesthetic, and again, that very sophisticated surgery. So this is what happens if you have growth and you lose, if it grows up, you lose your peripheral vision. So so this is obviously an American picture and tunnel vision of the White House, but you can see that your visual fields come in. This can be actually hard to pick up, and so having formal visual field testing in pregnancy is usually arranged. So that's the acromegaly, might get worse. We want to stop the medication, so we're kind of taking a risk of 9 months without the medication. And if the growth hormone is high, babies need oxygen, so sleep apnea, we want to make sure that the mom is getting enough oxygen through pregnancy. Your whole nose gets more congested when you're pregnant, so it does tend to get worse. Blood pressure normally goes up in the last part of pregnancy. There are safe medications, but it needs to be monitored, because if it's not treated, you can end up with an earlier delivery. And diabetes is much more common in women with acromegaly, and we need to screen for that and test it. Many women will get numb hands in pregnancy from carpal tunnel syndrome, but women with acromegaly will be more likely to get that. And usually we would use splints and not do anything else during pregnancy. So what about after the baby is born? So, again, most women do, if they can get pregnant, do great during the pregnancy. So one of the, again, big believer in breastfeeding, and you can restart the somatostatin analogs, and it's really kind of, if anything you have to give by injection is unlikely going to give the baby a problem by taking it by mouth. Because if it causes anything by mouth, we would give it to you by mouth. Why give it by injection? So in general, medications that require an injection, even if there was some in the breast milk, the baby gets it by mouth, so there'd be unlikely any effect for the baby. Dopamine agonists actually lower your prolactin level and are the medications we use to stop women from breastfeeding, so we can't use those ones until breastfeeding is over. And then lastly, will my child have acromegaly? Extraordinarily rare. I'm not the expert in genetic causes of acromegaly. We know there are gene changes within the tumors that produce the growth hormone and cause the acromegaly, but very, very few of them are genetic transferable causes. So there are a small number of rare genetic causes that are inheritable. They usually come with other things besides just acromegaly. So in general, the child is not exposed to high growth hormone in utero and will not develop the same condition. So this is just kind of a case that summarizes what we talked about. So the woman who had amenorrhea and became pregnant 1 year after surgery, she discontinued the octreotide at the diagnosis of pregnancy, but had to restart at 12 months due to the tumor burden getting larger and the headaches and signs of excess growth hormone. She delivered a healthy baby boy, and postpartum, there looked to be a slight increase in size. Her IGF-1 went up postpartum, so we increased the octreotide, and she was able to successfully breastfeed. So in summary, acromegaly can be associated with difficulty becoming pregnant, and in fact, difficulty becoming pregnant can be the first symptom that then leads down the path of diagnosing the acromegaly in the first place. And there are complications during pregnancy, both from if the tumor, although rare, can increase in size, needing to be off the medication, but also the diabetes, high blood pressure that needs to be monitored very carefully. However, in most cases, pregnancy can be very safe, and should not be, in my, again, biased view, discouraged for women with acromegaly. And I will say men, again, should be, have their fertility protected as well as they undergo treatment, either surgical or radiation treatment. So I'll just end there. Thank you.